Okay, distinguished Professor Hang Yiu, dear colleagues, ladies and gentlemen. Firstly, please allow me to extend a warm welcome to the session of ACE PCI program. ACE PCI program was hosted by the Interventional Cardiology Council of Asian Heart Society, and I'm the chairman of this council. And it's really my great honor to co-chair this session with Professor Yao, and Professor Yao is the vice chairman of the International Council of Asian Heart Society. And today's topic is focused on the intravascular imaging, how to optimize PCI, and very glad to have very excellent experts from Hong Kong, from Australia, and I do think today's session will be a great success. And next, I'd like to invite Professor Yao to host today's program. Professor Yao.
Thank you, Professor Lee, and everyone else online. So it's our great pleasure to invite everyone to join our ACE PCI program today. So as mentioned by Professor Lee, this is a platform associated with the Asian Heart Society. And of course, this is the interventional chapter, and we have already several online meetings, which is extremely successful, attracts many delegates from all over the world to participate in this program. So today we are honored to have interventionists from Hong Kong as well as from Australia to discuss and to share about how intravascular imaging would improve our PCI outcome. So again, thank you, Professor Lee, to be my co-moderator today, and of course the rest of the team in Harbin. So I think it will be a success as usual, but without further ado, I think we should start our program first by doing the case presentation. So maybe the next slides for the CV of Brian. So Brian is for a doctor from Queen Elizabeth Hospital, one of the biggest hospital in Hong Kong, and of course doing a lot of interventions. I know he is a fellow, junior fellow from Queen Elizabeth Hospital, working with Esmond Lam, who is going to be our panelist today, and of course our another speaker, Dr. Lam, later. So Brian, we will be very happy to listen to your case presentation. So maybe perhaps we will let you share the screen. So Brian, thank you.
So thank you, Professor Yiu, and thank you to the organizing committee for inviting me. It's my great pleasure to be on this platform, sharing with thousands of audience. Today, our theme is imaging optimization of PCI, and I've prepared several cases to share with you. So my name is Brian, and I'm from Queen Elizabeth Hospital in Hong Kong. So just a brief few slides on my topic. So today I will be focusing on the management of calcium. And as we all know, because calcium is one of the biggest enemies of the interventional cardiology. And that's because the calcified lesion is associated with suboptimal stent expansion, increase in the device delivery failure, increase in complication rate, and also increase in the procedural time. And the degree of the calcium, especially the arc of the calcium, has been shown to be associated with the stent under expansion, and also the rates of the in-stent restenosis. And of course, there are different types of calcium, as we are all familiar with. The deep and superficial calcium, whether it's the concentric or eccentric calcium, and also as well as the calcified nodule, which is of course very notorious for its long-term prognosis. And here is why the imaging is so important, both in terms of the intravascular ultrasound as well as the OCT to guide our management during our PCI procedure. So today I will be focusing more on OCT because OCT is an excellent tool for guiding our calcified lesion PCI. The OCT-based calcium score, taking into account the calcium angle, thickness, and length, has been associated as well with the stent expansion. And it's important that it is in terms of the calcified lesion, we are not looking at total removal of the calcium, but instead we are aiming at the lesion modification, where we make some thin segment in the circumferential calcium and look for some dissection, controlled dissection before we apply the stents to optimize the delivery and the stent expansion. There are different tools in dealing with the calcified lesion in terms of the rotational atherectomy, intravascular lithotripsy, as well as the orbital atherectomy. But this is not the focus of my case presentation. There are some algorithms devised by the international societies in terms of making use of the various tools. And as we can see, intravascular imaging is one of the most important aspects in terms of our assessment, both OCT and IVUS. So without further ado, I will share 3 cases today. The first case is a 58-year-old male with history of PCI and ischemic heart disease with an impaired ejection fraction of around 25%, admitted to our units for non-ST elevation myocardial infarction. So this is the coronary angiogram showing a diffuse calcified in-stent restenosis over the proximal to the mid-LAD. And over the cranial view on the right side of the screen, we can appreciate there is also significant calcified stenosis down to the distal LAD. And there is a right coronary chronic total occlusion with retrograde from the left. So this time we are tackling the LAD first. We perform pre-dilatation because we need to allow the passage of the OCT device after the pre-dilatation. So just a quick reminder, there are some principles that we can make use of during the OCT. The MLD max, looking at the morphology, length, diameter for the strategy. And after applying the stent, looking for any dissection, apposition, and satisfactory stent expansion. So this is important. The MLD max will help us to tackle the calcified lesion. So we performed the first OCT run. And as we can see, I've taken some screenshots over the right side. We can all appreciate there is some calcium at the proximal segment, which is outside the O stent, and also in-stent calcified neoatheroma and significant thickness. And there are some tools in the software that help us to make the measurements of the lumen as well as the EEL, which will help us in terms of both the pre-dilatation as well as stent deployment. So in this case, due to the thick calcium, we chose to use a shockwave, which is an intravascular lithotripsy to the proximal to the mid-LAD. We pre-dilated the distal LAD with a 2O balloon and apply a drug-coated balloon. And then for the proximal part, we use a non-compliant 3-5 balloon. And this is the post lithotripsy and before stenting. As we can see on the right side, there is a significant luminal grain as well as good calcium cracking. So we have achieved a satisfactory preparation. And again, some measurements to help us with the stenting. So we stented with 2 drug-eluting stents, post-dilated according to the measurements of the OCT. And as you can see, in the later of the run, actually the OCT again highlights the importance of imaging in this case, because as we can see, there is some dissection over the distal stent edge, which may not be so easily appreciated on the angiogram. So we perform another DES overlapping with the existing stent. And the final OCT runs shows good results with no significant injury and good results. So this is the first case illustrating the role of the OCT both in terms of the pre-PCI as well as the post-stenting, looking for the complications. We move on to the second case, which is an older male with multiple cardiac comorbidities. This time admitted for non-exacerbation myocardial infarction, and the echo also shows coexisting aortic stenosis, so some valvular problems as well. So we take a quick look at the coronary angiogram showing a significant left main and triple vessel disease, also quite calcified as well. So just a quick summary, left main plus triple vessel disease and coexisting valvular disease. So of course, we talked to our surgeons for a possibility of open heart surgery. So in our meeting, due to the presence of unfavorable factors such as porcine aorta and the underlying existing comorbidities, so he is deemed to be a high surgical risk. So we discussed with the patient and he opted for high-risk PCI first. So we first performed the PCI to the right coronary, very calcified disease. So again, we use the OCT. As we can see, I've again made some screenshots for your quick reference showing the MLA of only 1.5 millimeters square and also some circumferential calcium as well. So we chose to, at that juncture, we chose to first use again the intravascular lithotripsy. But as you can see, even with the intravascular lithotripsy, the stent expansion was not the best. So this is the post-shock wave. As you can see, there's still significant calcified lesion. We perform another OCT run, but as you can see, although on the bottom right, there's some cracking, but the expansion is still not the best. So we decided to proceed with the orbital atherectomy using the diamond bag device. And post atherectomy, there is some luminal gain, and the MLA now is up to 2 millimeters square, and there is also some increase in the calcium cracking. So we further optimize the results with the shock wave again, using the intravascular lithotripsy again. And as you can see, the pre and the post, there is a better expansion. And repeated the OCT showing progressively improving the results. So this is just a quick comparison. And the sequential OCT shows after each step, the intravascular imaging indeed will tell us that there is an improvement and a successful calcium debulking with the various strategies that we use. And this is the role of the OCT. So we stented the RCA, and as we can see, there is a good results after stenting with a good expansion and good apposition and no significant dissection, and showing good final angiogram. So I'm moving quickly to the third case. This case, I would especially like to highlight the newer software available in the OCT, which is the 3.0 version, which there is some highlights in the software as well as the processing as well. 60-year-old male with angina symptoms, left main plus triple vessel disease, but the patient refused surgery. This time he is returning for stage PCI to the left side after we performed the PCI to right side last time. So the coronary angiogram shows again calcified disease over the left wing LAD as well as the circumflex, especially over the proximal circ, significant calcium, and also over the LAD as well. So we perform the OCT to the LAD, showing MLA of only 1.53 and as well as some presence of a calcium over the LAD. We initially wanted to perform the OCT to the circ as well, but unfortunately we cannot pass down the OCT to the circ. So we have to try to predilate with a non-compliant 2O balloon, but however, as you can see, this expansion is not good. So again, we decided to further perform atherectomy with the orbital atherectomy. And then repeat the non-compliant balloon at high pressure. Now we can pass the OCT. And I would like to highlight on the bottom right of the screen, with the updated software in a 3.0, now we can enable to quick pullback over only 1 second. And the obvious benefit is the reduced contrast use per OCT run without compromising a lot of the image. And as we can see on the OCT images, actually the image quality is quite satisfactory despite the quicker pullback and also despite the less contrast use. And there is again some dissection induced and some luminal gain as well. So we decided to proceed with stenting. For the LAD, we decided to use the balloon-based strategy with the non-compliant balloon. We performed the DK crush, double kissing crush in terms of the left wing bifurcation strategy. These are just the steps illustrating us performing the DK crush. And again, this is the quick pullback of the circumflex. And as you can see, satisfactory results with no obvious dissection and good stent expansion. And again, the LAD also shows good results. And the final angiogram shows a good result over the left wing bifurcation. So in summary, I hope I have demonstrated in my three cases that the imaging plays an important role in terms of especially the calcified lesion to guide our therapies and to optimize the stent expansion. In our last case, I hope I have demonstrated that the newer software will allow some of the better benefits, such as 1 second pullback, the better morphology assessment, and the stent planning, including the calcium and the vessel summary, and the use of various devices such as the intravascular lithotripsy and the atherectomy devices will enable better lesion preparation and results. So thank you for listening, and I look forward to the further presentation and questions from the panelists. Thank you.
Thank you very much, Brian, for the wonderful case presentation. Three interesting cases that I think deserve some discussion later. So I can see another panelist, Chris, is online. So hello, Chris. I know you're at, I think, 7:50 in Australia, so in Sydney time. So thank you for joining.
That's correct. Thank you very much.
Thank you. Yeah, Professor Li is our co-moderator from Harbin. He is online with his staff together to learn from every one of us here. So thank you, Brian. And we will be now going to start the talk by Dr. Lam. So I will pass the floor to Professor Li. So perhaps Professor Li could introduce Dr. Lam. Thank you. 前一个姓林的那个后台，对。
Okay, next speaker is Professor Lam Lap Tin. He is come from Hong Kong. From the University of Hong Kong, is a co-founder and the vice president of Innovative Cardiovascular Initiative and specialized in complex PCI and CTO procedure, and especially interested in intracoronary imaging, coronary physiology, mechanical circulatory support. And Professor Lin's topic is role of intravascular imaging for best PCI outcomes. Welcome, Professor Lin.
Okay.
Thank you very much for Professor Li for your kind introductions. And it is my great honor here today to share with you all our experience of intravascular imaging use in Hong Kong. Can you all see my slides?
Yeah, very clear.
Okay, thank you very much. Thank you, Brian have mentioned a few cases. This is illustrated the elegant use of intracoronary imaging, and I'm trying to looking at from other perspective using more data support what is the role of intravascular imaging for achieving best PCI outcomes. From the ILLUMINATE-3 trials, we understand that OCT-guided PCI could achieve a greater stent expansion than angiography guidance alone, and it has also outperforms IFIS and angiography in the reduction of major malposition and major dissection. However, could these results improve the clinical outcomes? Following that, the ILLUMINATE-4 trial randomized the patient who are with high-risk background or with high-risk anatomy into either receiving OCT-guided PCI and angiographic PCI. In each group, there are 1,200 patients. The primary outcomes found that OCT group has a larger final minimum stent area that resulting in lower risk of 2-year stent thrombosis. However, the primary endpoint showed that it is a neutral effect of similar 2 years target vessel failure, comparing the OCT group and the angiographic group. Despite this neutral effect, I think we have to look into the details of these trials. If we look into the final OCT MSA outcomes, using the median cutoff of 5.2, actually we found that there is a difference of OCT and angiographic group. If the final minimum stent area achieved is larger than 5.2, there is a significant reduction in the target vessel failure at 2 years' time in the OCT group. No matter it's OCT or angiographic group, as you has achieved a good MSA. Second, the post-hoc analysis confirmed that the final MSAs of 5.2 millimeters square and significant edge dissections are independent predictors of 2 years target lesion failure. It corroborated with other clinical trials, including the CLEO OPCI-2 trial and the Forza criteria from Italy, showing that stent under expansion, low MSA, and major stent edge dissections are predictors of adverse outcomes after PCI in long run. And if we look into the subgroup of the ILLUMINATE-4 trial, if we exclude the patients only with high-risk clinical backgrounds, but must include those with complex angiographic lesions, including long lesions, bifurcations lesion, calcified lesions, CTO or in-stent restenosis, you can see at 2 years' time, there's a significant reductions of the serious MACE in the OCT group. And in the moderate to severe calcification group, the benefits is even further amplified. There's a 38 reductions in terms of the target vessel failure in 2 years' time. And other post-hoc OCT analysis using the post-OCT VFR identified and other independent predictors of VFR cutoff 0.9 that is could predict 2 years target vessel failure. So for the ILLUMINATE-4 trial, it gives us an insight that although there's a apparent negative trial saying that there's a similar target vessel failure in 2 years' time comparing OCT and angiographic PCI, but actually it could not only reduce the lowest has a lower risk of stent thrombosis, but only if you could achieve the MSAs larger than 5.2, avoiding proximal edge dissection, has a post-PCI VFR larger than 0.9. These could predict 2-year target vessel failure. And the more the complex lesions, including long lesions, calcifications lesions, there will be more benefits we gained from the use of OCT. It is not just this Illumin 4 trial. Other trials, including the Occupy trial, which randomized patients who received OCT or angiographic guided PCI in complex cases, also showed similar outcomes. It reached a significant primary significant endpoint of lower MACE in 1 year time in the OCT group. It is mainly driven by lower risk of spontaneous myocardial infarction and ischemic-driven target vessels revascularizations at 1 year. And more importantly, it is the stent optimization criteria which pre-specify that the MSA stent expansion, avoiding major stent edge dissection and malposition, and missing lesions not stented is the important criteria. Because if you look into details for comparing patients who had their stent optimized as compared with those without stent optimizations, there's a huge difference in terms of cardiovascular outcomes. There's a significant reduction in myocardial infarctions and revascularizations in the future. IVUS also showed similar results. This IVUS XPL trial showed that with long-term follow-up 5 years' time, the use of IVUS improved clinical outcomes, especially for those who met IVUS predefined stent optimization criteria. There's a further additional reduction in terms of the MACE. Similar study has been performed in China as well. The Ultimate trial is an all-comers coronary lesion trial comparing use of IVUS and also angiographic PCI. 3 years' time, IVUS improved clinical outcomes, but it is specifically also important that in optimal IVUS guided PCI, the gain, the benefit is you can see is amplified. Looking into example of the Ultimate study, the pre-specified stent optimization criteria include the MLA of the stent segment is larger than 5 mm², or the stent expansion is larger than 90%. The plaque burden should be less than 50% at both proximal and distal edges, and there should be no significant dissection. And IVUS defined optimal PCI was only determined if all these 3 criteria are simultaneously achieved. This is the diagram showing the plaque burden overload at the edge, stent under expansion, and detection of edge dissection by IVUS. There are similar OCT studies showing that if you land a stent at as a plaque burden more than 50%, especially with lipid plaque, it will prone to stent edge restenosis. Taken into account of 22 large randomized trial into a network meta-analysis, which include 15,000 patients, which is published in 2024. Overall speaking, use of intravascular imaging could basically reduce all outcomes, including target lesion failure, cardiac death, stent thrombosis, target revascularizations, all-cause death, target vessel MI, and all MI. And the outcomes were similar for OCT-guided and intravascular ultrasound-guided PCIs. And IVUS or OCT, which one is better? Venue complex PCI study give us informations. This is a complex PCI study, randomized patient who received intravascular imaging or angiographic PCI alone. Use of IVUS or OCT, it depends on the operator choice. There's a few things we can notice. First, use of either imaging could significantly reduce improve the outcomes up to 2 years' time, and it still have a good outcomes up to 6 years. And the improvement is particular noticed in the complex subgroup in the chronic total occlusions, unprotected left main diffuse long lesion, and severe calcified lesion. And I have to address repeatedly that the image guide PCI with optimization had the most benefits gained from this study of reductions from 14% of MACE from angiographic guided PCI to 11% to image guide PCI without optimization, and down to 9% with image guide PCI with optimization. And similar results have been achieved by the Octavus study, which is a study compare use of OCT guide versus IFS guide imaging. The results between two imaging modalities are similar, except in case of in-stent restenosis, OCT seems outperforms IFS. Therefore, use of intracoronary imaging has a lower risk of cardiac death, target vessel failure, myocardial infarction, and stent thrombosis. Maximal clinical benefit is only attained if optimal imaging criteria is achieved. IFS and OCT both provide comparable clinical benefits. The more complex the lesion on the procedure, the greater the imaging benefit is. And if we look into different subsets of different lesions, like bifurcation lesion, obviously from the background of different study, we know that bifurcations PCI has a higher, has a poor outcomes than those compared with non-bifurcation PCI. And one particular trial, the October trial, which is published 3 years ago, looking into a 1,200 patients randomized into either OCT arm or angiographic guided PCI in true bifurcations lesions. And it showed that at 2 years' time, OCT has a significant reduction of the composite endpoint of major adverse cardiovascular events. But it is interesting to look into the protocol of this October trial. Why does OCT could improve the outcomes? There's a mandatory 4 runs of OCT requested by the protocol. Obviously, it's the pre-PCI OCT runs and the post-PCI OCT runs in both the main branches and the side branches. But in particular, there's a one request of the OCT runs after the main branch stenting and rewiring of the side branch. Not only look into the stent edge dissection position and also the stent expansion, but particularly we need to check the position of the rewiring. Is there any abdominal rewiring, unintended stent deformation? Because there's a 5.4% of the accidental abdominal rewiring noticed, 9.3% cases with unintended stent deformation. If we notice these particular information, however, left these deformations or problem untreated, about 23% of the case will come back with adverse cardiovascular outcomes. On the other hand, if we address this abdominal rewiring or unintended stent deformation and treat it, 0% of this case will come back with adverse outcome. So it is actually very important that not only use the OCT, but we need to address the information, the feedback that given by the OCT, and we react and perform stent optimization. There's a particular case that I done a few weeks ago. We do a DK crush. After the first kissing, we rewire, we notice there's some malformation on we perform OCT and notice there's a abdominal rewiring and unintended stent deformation as described in the like the October trial. And you can see the abdominal rewiring is only tiny, is only like in the middle of the side branch. So we make use of the OCT to rewire again, and the second wire again is in the false lumen. That's why we need to use a third wire to put it in the true lumen and address it by OCT, make sure it is all in the true lumen, and then we perform the following steps of the DK crush and yielded a good results in the end. Talking about bifurcations, it is unavoidable that at some time we need to use a two-stent techniques. In particular, DK crush is a favorable stenting technique in Asia and also in China. The DK crush 8 trial that is just published recently, showing that IFS guided PCI using DK crush improved outcome. But one important message is that if you use IFAS guide PCI, but with suboptimal predefined criteria, the outcome is actually similar to angiographic guided PCI. There's no difference if you use IFAS, but you do not respond to the message or the errors you notice in IFAS. Only if you follow all the steps, you notice the problem given by the IFAS and you addressed it, you will achieve a very good outcome of only 2.6 target vessel failure at 1 year time. How about left main bifurcations? In Occupy trial and Renovate complex PCI trial, they both have significant positive effect of OCT image-guided PCI favorable in left main bifurcations lesion. Although in October trial, in left main subgroup is negative, but the direction is also towards the same direction. We have to take into account of the protocol. It allows IFAS use in 35% of the case of angio-guided left-wing PCI group. One outlier is the latest publications of the optimal trial done by the UK group, which is published in the New England Journal 3 months ago, showing that there's a neutral effect of the IFAS guide PCI versus angiographic guide PCI in left-main PCI. But there's some criticism that about this trial, although we cannot exclude this negative trial. It is an important negative trial, but we have to look into the details. This trial was conducted in high volume centers by operators who were already highly experienced in IFAS use prior to study initiation. There's a chance that it results in a form of angiographic recalibration whereby operators were able to achieve stand optimization deployment with angiographic alone, informed by the prior intracoronary imaging experience. Therefore, the effect of IFAS could be attenuated. And on the other hand, the final IFAS is actually only lead to corrective measures optimization in 30% of the case, and 1/3 of the case was noticed that the optimization criteria was not met. So basically in this study, 1/3 of the case optimization criteria is not met, and only 1/3 of the case we notice error, we do further optimization. So I'm not sure is this the reason behind leading to this is negative trial, or there's a improvement in the PCI techniques over time and also the devices, so that now we have a improved overall PCI to left main outcomes. Nonetheless, there are other studies, important studies need to address in left-wing bifurcations PCI, is that a Korean big retrospective registry in upfront two-stand PCI in left main, if we achieve a osteo circumflex minimal area more than 6 and osteo LAD area more than 8, it will improve the long-term outcomes. So taking an example, this is a case with calcified triple disease surgical turn down, left main bifurcation lesions, RCA CTO. We perform left side procedures and we perform IFAS, identified circumferential calcifications, and we often use shockwave intravascular lithotripsy to address the calcifications. Similarly, in the circumflex, we address the calcification using the intravascular lithotripsy. And more importantly is that we need to do post-IFAS imaging to make sure that the stand area is achieved at the best outcome. In this particular case, at the osteo LAD and both osteo circumflex, the MSA is more than 8, and in the distal left main, the area is more than 13, and we accepted these results. And the role of intracoronary imaging in calcified lesion, I will just go briefly because Brian has mentioned a lot about it already. Basically, it is always challenged in calcified lesion because it could lead to stand under expansion, high-risk in-stand restenosis, coronary artery perforation if use ultra-high pressure dilatations, and moderate calcification will increase risk of cardiac death and target vessel MI and revascularizations. OCT predefined criteria including thickness, length, and calcium arc is important negative predictive factors of long-term outcome. IFAS, on the other hand, also have similar criteria using the calcium arc, thickness, calcium nodule, and the vessel size to advise you whether to use upfront atherectomy or not, which could affect the long-term outcome. And these studies and steps are endorsed by the SKY expert consensus requirement, saying that the use of intravascular imaging criteria could help decide whether upfront atherectomy or intravascular lithotripsy is useful or not. And like, for example, in this particular case, we notice a calcified RCA mainly is concentric calcification. Intravascular lithotripsy will help with this thick calcification, and we confirm good outcomes after stenting with good expansions confirmed by the OCT in the end. On the other hand, in this case, the LAD showed moderate angiographic calcification only. However, if we put down an imaging device, you notice there's a very, very thick calcification inside a mid-LAD. Therefore, we need to use upfront intravascular lithotripsy in order to achieve a very good stent expansion. Similarly, a angiographic moderate calcifications lesion, the use of intracorneal imaging is not only quantify the amount, but notice whether it is concentric or eccentric. With this thick eccentric calcified plate, the best method is use atherectomy like orbital atherectomy. We perform Diamondback system load a few runs to this eccentric nodule, and then there's a good controlled dissection and calcium debulking performed, and we confirmed a good angiographic and post-PCI OCT outcomes. So intracorneal imaging identifies high-risk feature of adverse outcome, including using the calcification arc, thick calcification, long segment, eccentric calcified nodule. Intracorneal imaging helps to select the best calcification modification strategy, sizing balloon, and stent. Post-stenting imaging ensures optimal stent expansion. And in ACS, there's a IFAS ACS study showing that even in ACS, no matter STEMI or NSTEMI, unstable angina, use of IFAS could further improve the long-term clinical outcomes. And in case of myocardial infarction, but you could not find any culprit lesions in angiogram. Actually, in one interesting study showing that OCT could actually identify 50% of the hidden culprit lesions, including plaque rupture, plaque erosion, thrombus, intraluminal bumping suggestive of coronary spasm or coronary artery dissection. And this is a debatable and an interesting study, erosion-free study, STEMI. They do a POBA, thrombectomy, restorative refill, and then they perform OCT, and they find favorable OCT criteria to defer stenting. And actually, the outcome at 40 days was similar to those with stenting group. So I'm not suggesting you all cases could be deferred stenting, but OCT is a quite powerful and useful method to look for the culprit and adjust your treatment, even in ACS case. And in ACS with non-culprit lesions, sometimes you want to identify high-risk vulnerable plaque, which is a trendy procedure nowadays. And no matter you use OCT to detect thin cat fibroathyroma or use the IFAS to detect high plaque burden, low MLA, or thin cat fibroathyroma, all these features could suggest a vulnerable plaque and predict adverse cardiovascular outcomes in the non-culprit vessels in the future. And almost coming to the end, the use of intracorneal imaging in ISR. ISR obviously is a notorious situation that we don't want to encounter. And ISR PCI has a adverse outcome as compared to de novo PCI. And retrospective registry suggests that use of intracorneal imaging could improve outcomes. The reason is that it could identify the mechanism of ISR, including that it be a stent expansion, because stent expansion is an important factor to predict further stent expansion in the new stent implantation in ISR, or some biological factor including neointimal hyperplasia or neoatherosclerosis, because these factors carry different prognosis. Neoatherosclerosis has a higher rate of MACE in the future, especially in those cases of lipid lipidic neoatherosclerosis. Just one case example. These case examples, we notice there's a calcified lesion stent ISR. However, the mechanism is that first, at the proximal segment, the stent is undersized and underexpanded due to eccentric calcification. And at the distal stent edge, we notice there's a calcified nodule extending from the normal segment into the distal stent edge, leading to stent underexpansion as well. So treating with calcified nodule and stent underexpansion, calcium outside the stent, the best method is that we need to use rotobation to crack the calcium outside the stent and high pressure pre-dilatation, and so that we yield good outcomes. And IFAS recheck and showing that there's still stent under expansion. Use a larger balloon matching with the vessel size, confirm with IFAS with good stent optimization in order to gain the best outcome. Intracoronary imaging is crucial to understand the mechanism of ISR, namely the mechanical or the biological factors, but often it is mixed, and tailored treatments is preferred to target treatment for mechanism of ISR. In the last, just a few words about CTO PCI. IFAS is very useful in identifying in ambiguous proximal cap. In this particular case, we're not sure where is the proximal cap is, so we put down the IFAS into the side branch. We identify the proximal cap co-registered with the location on angiogram, and we perform puncture easily to overcome the proximal cap ambiguity. Second, IFAS could also facilitate the reverse card because we want to understand whether our antegrade and retrograde wires are in the same true lumen or in the false lumens, or they both located in different compartments. Take an example in this particular case, I would say CTO with its lateral retrograde. At some point, I need to use a reverse card to tackle this case, and I perform reverse card. Difficult case, need a CP12 to do reverse card. And after that, but it wouldn't go into the true lumen. That's why I put in an IFAS and from the antegrade side to check the retrograde wire positions. It may be difficult to notice, but there's a spot of wire at the 6 o'clock around here. It's actually the retrograde wire still in the false lumen. Therefore, I need to use a bigger balloon sizing with the vessel and do it again. However, it's still not successful. You see the wire is still outside. And then because it may be a calcified segment, I choose a more non-calcified segment, do a extended reverse card at the proximal segment, and finally it went into the true lumen. However, before standing, we noticed that from the mid to distal segment, there's a the wiring is subintimal. If you stand it, the large artery branch will be compromised. Therefore, using this IFAS information, we use JO balloon technique to make sure there's a patent RV marginal branch in the end. So we confirmed a good stent expansion using the IFAS as well. It is important, as we mentioned before. There are some fancy techniques used like slipstream technique or IFAS IFAS tip detection method that I'm not trying to mention today. And there's a retrospective CTO IFAS study showing that IFAS use could reduce cardiac death and myocardial infarction, and similar in this study as well. So, ladies and gentlemen, I would like to make a conclusion that the use of intracoronary imaging actually could have improved the clinical outcomes by lowering the risk of cardiac death, cardiac vessel failure, myocardial infarction, and stent thrombosis. Maximal clinical benefit is only attained if you change PCI strategy according to the intracoronary imaging findings, and the final optimal imaging criteria is achieved. IFAS and OCT both provide comparable clinical benefits. The imaging modality may be guided by the clinical scenario and the relative strengths of each device. The more complex the procedure, the greater the benefit we gain from the imaging. It is highly useful in complex cases, including bifurcations, left main bifurcations, calcified lesions, ACS, long lesion, in-stent restenosis, and CTO. Thank you very much.
Okay, thank you very much for Professor Lin for your excellent lecture and wonderful cases. And we have two distinguished panelists from Australia and Hong Kong, Professor Christopher Wong. Any questions or comments?
So Chris, maybe I will introduce you. So maybe 我们去王教授的那个简历。后台对 So Professor Wong is a good friend of mine. He's now a consultant interventional cardiologist at the Concord Patrician General Hospital and a senior lecturer at the University of Sydney. So he is a wonderful interventional cardiologist, and he does a lot of complex PCI. So this is our first panelist. The second panelist, maybe we can also introduce Dr. Esmond Fong. So 后台我们去方教授的那个简历。So Esmond Fong again is a very young, yet very experienced cardiologist from Hong Kong. He is now the associate consultant at the Queen Elizabeth Hospital. He, as mentioned before, he does a lot of complex coronary interventions as well as peripheral artery interventions at Queen Elizabeth Hospital, and also the founding president of the Innovative Cardiovascular Initiative. So we are grateful for both of them to be our panelists today. Perhaps I would invite Chris to give a few comments about the cases as well as the talk and some questions for Dr. Lam and Dr. Ng. Chris?
Yes, absolutely. No, thank you for having me. Thank you for that wonderful introduction. Can you all hear me? Okay?
Yep.
Great,
Yes.
fantastic. So, Dr. Lam, that was a real tour de force of all the, fantastic data that you're presenting, really showing that, imaging-guided PCI is the future. And there is a lot of studies now which you have shown very clearly that imaging-guided PCI leads to better outcome, especially if you can achieve an optimal result, and if you've prepared the lesion well. Brian, you also showed 3 fantastic cases, very complex lesion subsets, which are the ones that benefit from intracoronary imaging. So I just want to congratulate you both on, presenting some wonderful talks, and that's highly educational for us. One comment I will make is that, we've come a long way from intracoronary imaging in the past. We focus a lot on, doing the post-PCI optimization, but now I really think that a lot of the benefit for intracoronary imaging is in the pre-PCI stage. Brian, you showed in a few cases that you upfront went with a shockwave based on calcified neoatherosclerosis. Dr. Lam, you showed a case where you had to rotor and underexpanded stent, and these are all strategies that can actually change your outcome. There's nothing worse than, just doing not proper predilation based, and not doing imaging guided pre-PCI planning, putting in a stent, then doing your imaging and showing a severely underexpanded stent, and then you really don't have many options other than shockwave and high pressure balloon dilatation to optimize the stent. And these are the cases with severely calcified lesions where if you're overly aggressive trying to optimize the result once you've got the stent in, these are the cases that lead to coronary perforation and bad outcomes. So I think it's really great that we're all moving towards planning the PCI and prepping the lesion well based on intracoronary imaging, and then checking the result. And definitely doing intracoronary imaging runs after preparing the lesion is so important to make sure that before you put in that stent, you're going to get good stent expansion. And if you can't achieve that, sometimes vessels are just very calcified and very bad. It may be better to move to a DCB strategy. So those are my comments. My question, I guess, to everyone on the panel and to Dr. Lam and Brian is that, there's so much enthusiasm for intracoronary imaging. And then this year when Optimal came out, you would have thought that left main PCI, that's the subset where you would really gain a benefit. And has that changed your practice at all? Are we moving more towards angiography-based PCI if you think you're a good operator and you have IVUS eyes, or do you still believe in intracoronary imaging in 100% of your cases?
Perhaps Esmond could.
Yeah.
also give us some comments on the questions about left main stenting.
Absolutely. Thank you, Professor Yiu. Thank you, Professor Li. Thanks, Chris, for the very good summary. I enjoyed both of your talks very much, with a very good summary of the current data that we have, and also, I think more importantly, the use of intracoronary imaging in different lesion subsets, and that would definitely give us a lot of guidance clinically on how to optimize our PCI. And of course, I enjoyed the cases that Brian has just presented. So I have two comments. I think the first one would be, I think the most important point in utilizing intracoronary imaging is that you really act on the result of your intracoronary imaging, as highlighted by Tin. So I was taught as a fellow, if you don't act on your intracoronary imaging result, you just don't do it at all. So we really need to be aware of what we are looking for, and be ready to pay that extra steps forward to really optimize the lesion preparation, stent optimization, and also to notice whether there's any complications, most of the time medial dissection, to get a better outcome. And that's where the benefits of our intracoronary imagings are derived. And the second point I would like to highlight is the use of intracoronary imaging in ACS, particularly STEMI patients. So I think in our locality, in the Southeast Asian region, we do have a much higher utilization of intracoronary imaging than in anywhere else in the world, because of reimbursement issue, because of the different practice. But particularly in STEMI patients, we know a lot of STEMI patients, they come in, there are a lot of operators would tend to undersize the stent in a STEMI case, which when the patient come back, we know that the vessel is actually not that small. And so I think intracoronary imaging would definitely play a role, even in those hyperacute scenario, which definitely would have a benefit for our patient. So I have two questions, one for Brian and one for Lap Tin. So for Brian, I think you have illustrated the evolution of OCT throughout the years. So the first two cases were done by the older OCT systems, Ultron 1.0. Of course, there's already some features in how to really look at the calcium, the arc of the calcium, the thickness, etc. by the AI features. But maybe you can highlight to us what's the latest development. So you mentioned about the Ultron 3.0 system, which of course has additional features to the old system. So maybe you can highlight to us how it would help in redefining our PCI strategies. And my question to Lap Tin would be, as you just showed us the recently published optimal trial from the New England Journal of Medicine. So unfortunately, it's a negative trial, but it also highlights a lot of this is the clinical reality. So a lot of times how we are really selecting our patients and how we are utilizing that particular tool makes a big difference in whether we would achieve a good outcome. So in your opinion, my question is, what do you think is the future of intracoronary imaging? So what do you think is the missing step? And as for future development, what are some of the keys that you think may bring the benefit of intracoronary imaging to an even greater extent than the data that we have currently?
So thank you, Dr. Chris and Dr. Esmond and everyone for your kind comments, and learned a lot from Dr. Lap Tin's lecture as well. So just to respond to Dr. Esmond's question, because it's quite new, the software upgrades in Hong Kong is only been recently launched in the past 1 to 2 weeks. And the case that I presented is actually just performed last week. So some of the updates of the new software, other than the obvious benefits of the fast pullback, which provides a comparable image quality but with less associated contrast use. So in our experience, every OCT run, we only use around 3 to 5 mil of contrast. If we are using, for example, 1-to-1 contrast saline or even 1-to-2 contrast to saline ratio. There are also some improvements in terms of the AI in detecting the calcium as well as the lipid. Of course, some of these features us as physicians should be able to recognize, but indeed the AI protocol will be able to also help us to delineate whether it is calcium or the lipid as well. So these are some of the strategies as well. And also some improvements in terms of the 3D images as well as some of the AI calculations. These are some of the major improvements in the latest software, which of course will help us in terms of using such intravascular imaging. So in my case presentation, I focused on the OCT, but of course, IVUS is also another excellent tool which has been widely used in both my center and as well as in China, in Asia as well. So I'm happy to share these cases and to highlight some of the newer updates in terms of the available software and how it will help us in terms of guiding our daily PCI procedures as well.
Thank you. So although time is running late, but I think addressing Esmond questions about left main stenting, I think the study, they included experts, interventionists, and perhaps that would be one of the reasons because of the ceiling effect. That's most of these cases are straightforward, and therefore the outcome is not that bad anyway with angiographic. But I wouldn't say that we shouldn't be doing intravascular ultrasound or other imaging techniques in left main stenting, especially for non-experts or early interventionists. So thank you for the excellent questions and answers and Tin's wonderful presentation. So I would pass it to Professor Li. Do you have any final comments, or the panel from your side? Any comments or any conclusions before we end today's session?
Okay, we still have 3 panelists from the first affiliated hospital, Harbin Medical University. And in my left side is Professor Cao Yang. So recently, under the guidance and help of Professor Yao, the Interventional Cardiology Council of Asian Heart Society, we just finished the expert consensus on the management of calcium nodule, and it is under revision at present. And Professor Chao, would you like to give a brief introduction of this expert consensus to the panelists and the audience?
Okay, thank you, Professor Yao, Professor Li, and all the panelists online. I'm Dr. Cao from the first affiliated hospital of Harbin Medical University. And I want to be really grateful to have this chance to participate in this online session. And I want to say that I learned a lot from the case sharings and the topics. I think these 2 topics, share the very latest update of the evidence-based, intravascular imaging helps to optimization of the PCI. And also the 3 cases give me very deep impression. It's very, a great demonstration of our daily practice, how we identify the lesions, how we make our plans to make the PCI, and finally, most importantly, to see the good result, especially the distal dissection cannot be easily detected by the angiography, and we make another stand. Actually, I have some questions, but I think we'll save the time for the other panelists. Actually, I want to take this chance to make our great thanks to Professor Yao Qiheng for his great contribution in the help of the consensus of the calcium nodule. We all know that calcium nodule is a special kind of lesion. I think we just mentioned a lot, bifurcation, left main, diffuse lesion, etc. But I think calcium nodule is very unique. Many experts just guarantee that the good stent expansion, minimum stent area is the guarantee of good prognosis. However, when we meet calcinology, I think everyone has the experience. Even though that you make a good stent expansion after maybe 6 months, 1 year, the patient come back, and at the exactly spot of the calcinology, I mean, there is a calcinology regrowth into the stent structure. So we think this is very unique. Sadly, we didn't find any strong or hard evidence, very large RCTs, to prove which kind of devices or flow chart to do is the best ways to support to treat this kind of lesion. But we try our best to collect this kind of case reports, some suggestions by the professors, some devices to try to treat this kind of lesion. So currently, our idea is a combination of intravascular imaging, and I myself make the definition of some kind of NC balloon palpation, this kind of I think idea. First thing is that we will use IVI, for example, IVUS or OCT to identify this is calcinology, even though the ultrasound cannot make a sub-classification, whether it's eruptive or non-eruptive. One thing is that we identify as calcinology, so it's different compared to the other kind of lesions. And then we try to use NC balloons to try to dilate this lesion first. Because sometimes, even though with the image of OCT, it's hard to predict whether this non-eruptive calcinology is dilatable, I mean deformable or non-deformable. So we try to use NC balloon 1-to-1 ratio to try to dilate this lesion. If this one is deformable, I think it's relatively associated with a good expansion. Either you would use a cutting balloon, squaring balloon to make the plaque preparation of this lesion, and then if everything is fine, we put DS in it, because there is once again, there is no, I mean, guarantee or evidence to show that DCB is superior to DS over the calcinology. And if this plaque is relatively non-deformable, I think it's relatively good choice to make debulking devices. No matter you are available of rotablator or IVL or orbital atherectomy system, anything is fine whenever you have it. Of course, using the IVI, you should check the wear bias, whether it's favorable or non-favorable. Once again, it's favorable, like the case demonstration. It's very close to the target. I think relatively this result is good. You could make some debulking, reduce the amount of the calcinology, I think, following the, once again, NC balloon dilation to make a DS procedure. Currently, this is our idea. I'm not going to say this is evidence-based flow chart, but I think currently, following some published papers, for example, several papers by Dr. Ali and a series of papers using the IVL system for the calcinology, I mean, this kind of etc. I think this is our idea for the flow chart of the calcinology. And I think if all the panelists, especially Dr. Yao and Dr. Chris, Brian, and Dr. Lam, if you have any suggestions for the treating flow chart and your ideas about the treating calcinologies, as well as calcinology-related target lesion revascularization, I think is really good for us to hear your opinion. Thank you much. Thank you very much.
Okay, so Professor Chao already gave a brief introduction of the consensus. So I do think it will be published in the near future, and we'd like to get more advice for the treatment of the specific lesion calcinology. And really just like Professor Brin, Professor Lap Tin introduced, intravascular imaging is very helpful for the challenging case intervention. Even in some cases should be mandatory. But also the intravascular imaging is helpful, very helpful, but still have many limitations. And recent years, based on the AI technique and CT angiography, so we, my team in one system, we called it the COVID system. The system could clearly show the 3D distribution of all the kinds of lesions, including the calcified lesions, and is very helpful in the challenging case. And Professor Wang Dingyu, would you like to give a brief introduction of the system to the panelists?
Yeah. First of all, thank you, Dr. Yao, and all the speakers and panelists. But I want to introduce the COVID system. I like intravascular imaging systems such as ALS or OCT. If it's possible, I'll use 100% of my cases. But as we all know that if we want to planning the procedure before the PCI procedure, we cannot use the ALS image or OCT image, and sometimes we cannot advance the catheter beyond the line. So coronary CT angiography is very helpful in this situation. But as we all know that coronary CT angiography is very difficult for some freshmen, and it needs a long learning curve, and all the coronary CT angiography cannot show us the coronary artery tree and the distribution of the plaque clearly. So we developed the COVID system. We call it the coronary visualization, coronary visual intelligence system. And in this system, we can show to the operators, to the doctors, and also the patients the plaque burden, the plaque distribution, and the latest version of this system. We can show the attack angle of the CTO lines. We can help the operators to clarify the distribution of calcified plaques and the fibrous cap before the procedure. So we have used this system in many complex cases, such as the Lessman cases, the calcified cases, CTO cases. It's very useful, and we hope that maybe in next meeting we'll show you the use of the COVID system and learn more from you. Thank you.
Okay, Professor Li Tiangai, do you have any comments or questions?
Thank you from all the excellent presentation from the speakers and panelists. I think just like Professor Chris Wong just mentioned, I think the negative result from optimal trial wouldn't stop us from the use of the SIs in the for the best PCI outcomes. So, but it does just open another window. Like in the past, we use ICIs to just measure the area, the lumen size, but maybe we should pay more attention to the character of the plaques. And also we can see the physiologic function of the plaques. So our team has done a lot of research into the clinical practice of doing using the AI-assisted CCTA to characterize the plaque content, whether it's lipid or whether it's calcifications. And another thing we do is we use invasive coronary image to calculate QFR to see the physiologic aspect of the coronary flow. So I think in the future, ICIs combined with other AI and other very advanced technologies will help us to get more benefits from this treatment, PCI treatments.
Okay, so because of time limitation, we have already beyond the schedule. So finally, I would like to express my sincere gratitude to all the speakers, Professor Brin, Professor Lam Lap Tin, for your excellent lectures, and my sincere gratitude to the panelists. And I also want to express my sincere gratitude to Professor Yao, and thank you very much for your contribution to the Interventional Cardiology Council of Asian Heart Society. Thank you very much for your excellent work. And I'd like to invite Professor Yao to give the close remark.
Thank you, Professor Li. it should be my honor and the rest of us to participate in this wonderful program led by you. So hopefully in the coming years, we can work closely together, not only to have lectures, but also we can meet up in person and to do some collaborations and research and publications together. So thank you again, Atin, Brian, Esmond, and of course, Christopher, for joining today's program. So thank you, Professor Li, and hope everyone will have a nice week ahead. And of course, the wonderful World Cup coming up. Thank you.
Okay. Bye bye. See you
Bye-bye.
next time.
拜拜，谢谢，谢谢李教授。
谢谢，拜拜。
再见，再见。
拜拜。